4, 3, 2, 1. We are live, sir.
Welcome to the Edward Jenner Hall. So we have a host of distinguished faculties from all over the world here, waiting for excellent deliberation. I am the moderator, Dr. Ihu Basu, and I am introducing the chairperson of session 1 of the parallel session in Hall B or the Edward Jenner Hall, Professor Pravid Kosh. He actually needs no introduction, but to be on the I am trying to introduce him very formally. He is a professor at Department of Medicine of RG Kar Medical College, Kolkata, which is a very renowned medical college. He has more than 35 publications in national and international forums, and he is the co-author of several books, including Geriatric Health in India and book on obesity. He has been a university paper setter and an examiner for a pretty long time. He has been awarded fellowships of FICP, FACP, and FRCP. So, welcome Dr. Kormakar to this session. Now, he will be chairing this session. I am handing over the stage to Dr. Kormakar. Dr. Kormakar, please.
Thank you, Dr. Ihu Basu, for all those kind words. Now we have come to a very important session, and there are 3 eminent speakers, national and international speaker. So first of all, without wasting time, I will pass on to our first speaker, who is Dr. Prasad Kulkarni. Dr. Prasad Kulkarni is MD, FCP, is a clinical pharmacologist with several years experience in new drug development, clinical research, pharmacovigilance, regulatory practices, and medical advice. He works at the Serum Institute of India Limited. Here he has been involved in the successful clinical development of several new vaccines, including, you all know, that is Covishield, that is COVID-19 vaccines, one of the most popular vaccines all over the world. And he is also attached to therapeutic large molecules. So he has more than 70 publications in journals like international important journals like New England Journal of Medicines, Lancet, Lancet Infectious Medicines, and many others. So with these introductions, I like to invite our most eminent, one of the most eminent speakers of this session, Dr. Prasad Kulkarni. So he will speak on role of, sorry for the interruptions. He will speak on role of Indian vaccines for globalization, focus on meningococcus and COVID-19 infections. So over to Dr. Kulkarni, please. Now the stage is yours.
Thank you, Dr. Karmakar, for your kind words. And I will try to be brief. Role of Indian vaccines for global use, and will little case studies of meningococcal vaccines and COVID-19. Just to give you a little historical perspective, India has been playing a role in vaccines since ages. And it is known that the original birthplace of inoculation, as it was called originally, was India and China. And in fact, in the 18th, there are 18th century accounts of practice of inoculation, and they trace it back to Bengal. By the way, Dr. Karmakar, you may be aware of this, and where it had been apparently used for many hundreds of years. There are also claims that inoculation had in fact been practiced in India for thousands of years and has been described in ancient Sanskrit texts. So that's about the origin of vaccination, and probably we can make some small claim on that front. And this is a painting by an Irish painter of a senior most Mysore queen of Krishnaraja Vadiyar III, who received her smallpox vaccine in 1805. And this was probably one of the first inoculations or vaccination that started in India. As you are aware, and this is the name of the room, Edward Jennar was the one who started the practice of smallpox inoculation, and then it gradually spread over the world and also came to India. So this was probably the first account of first, you can say, documented vaccination in India. And so under the British rule, the vaccination development started in India way back in the 19th century. And there was first laboratory in Shillong that was started to make smallpox vaccine lymph. After that, Hopkins started his his laboratory in Mumbai, and which was later renamed as Hafkin Institute, which started making plague vaccine. Then Kasauli in Himachal Pradesh, Pasteur Institute Kunur, Tamil Nadu. Then BCG Lab in Gindi in Tamil Nadu again. Cadila. Then of course the new private vaccines companies were started. Cadila, Biological Advanced, Serum Institute, Indian Immunologicals, Panacia Biotech, and so on. So basically, what we know is that vaccine production or vaccine development has a long history in India. Modern vaccine, and among the private sector, as you are aware, Serum Institute, Biological E, and so many other companies are there. In public sector, we have BIPCOL, Hafkin Institute, Indian Immunologicals, HLL, also labs in other states which are making polio vaccines. So if we look at the list of major vaccine manufacturers in the country, in the world, you can see that GSK, Sanofi are the two big giants, and of course followed by Serum Institute. Then you have Bharat Biotech, you have biological Shanta Biotech, Panacia, and so on. So Indian companies have been there at the forefront among the major vaccine manufacturers. Uh, uh, just to give you some idea that how vaccines are procured globally. So usually countries try to procure their vaccines on their own, but the remaining almost 60% of the doses are procured by the countries themselves. But the remaining procurement happens through either UNICEF or PAHO, Pan American Health Organization. Right? UNICEF is mainly meant for Asia, Africa, and CIS countries, whereas PAHO is meant for Latin America. And these agencies procure only WHO pre-qualified vaccine. And this pre-qualification is a very rigorous process. It happens after inspection of the facilities, dossier review, data is reviewed, vaccine vials are tested in independent labs, and clinical data is reviewed, and all that. So after this rigorous process, only then you get pre-qualification. Unfortunately, there are many Indian vaccines which are WHO pre-qualified, and therefore they are being supplied to these UN agencies like UNICEF and PAH. If you look at various continents, how much procurement happens, by which way, you will find that Africa mostly procures its vaccine through UNICEF, whereas Southeast Asia has a mixed model, some proportion coming from UNICEF, whereas some coming from self-procurement. Right. So every country has its own. Europe, of course, does mostly self-procurement, and so is the Americas. Of course, the North America is mostly self-procurement, whereas South America is through PAHO. Right. So, and then there is an organization called as Developing Country Vaccine Manufacturers Network, DCVMN, and you will find that most of these manufacturers are concentrated in Asia. India, of course, has many of them, and then there are few in Latin America and also Mexico and South Africa. But the majority are in Asia, and again among them in India. These are this is the list of developing country vaccine manufacturers with WHO pre-qualified vaccines, and you can see many Indian companies are there: Bharat Biotech, Biologically, Cadila, then of course Hafkin Institute, Panacia, Serum Institute. Serum Institute has 23. Now this number has gone to 27 WHO pre-qualified vaccines, which is the highest for any company. And as a result, Indian companies have been supplying to the global agencies like UNICEF and PAHO in a big way, And this procurement, if you just again try to see the breakup of the procurement with multinational companies vis-a-vis Indian companies, you will find that in Africa, for example, is the Indian companies which are giving the most. So is EMRO region, then Americas, and in Southeast Asia as well as Western Pacific region, right? So in most of the region, Indian companies are supplying a majority of the vaccines. So you can imagine our vaccines are playing a big role. If we look at Serum Institute per se, since 1992, Serum was the first company to get WHO pre-qualification for any vaccine in 1992. And since then, they have been supplying to these global agencies. And you can see that every vaccine practically, rabies, diphtheria, pertussis, tetanus, hepatitis B, HIV, OPV, IPV, rotavirus, measles, mumps, rubella, meningitis A, BCG, influenza. All these vaccines are being supplied, and the doses are in millions of doses, huge quantities. In fact, I can safely say that so far, more than 14 billion doses of vaccines have been supplied by Serum to different countries across the world. That includes 2 billion doses of COVID vaccines. Just to give you two case studies, as I said, meningitis vaccine. So in Africa, there is something called as meningitis belt, which is part of the sub-Saharan Africa, extending from Senegal on the west to Ethiopia on the east. 430 million population, at high risk of getting the disease. Devastating epidemics of meningitis, meningococcal meningitis, serogroup A, every 5 to 12 years. Attack rates were very high, and in 96, 25,000 people died. So that used to actually cripple those countries, some of the poorest countries, and these epidemics used to create havoc in the society. The young adults used to get affected the most, so the most productive population used to get affected, and there used to be chaos in the entire community, right? And and for tackling these epidemics, polysaccharide vaccines were used, but they were not doing a great job. They did not give long-term protection and did not have herd effect. So it was not a permanent solution. A conjugate vaccine was required, and therefore the African countries appealed to WHO for a vaccine, a cost-effective vaccine. No big pharma was interested to make a vaccine that was costing less than $1 a dose, right? Cost was and therefore Serum Institute was the only company, Indian company, which agreed to make that vaccine. They started as a partnership with PATH and WHO in 2001, and over the next few years, phase 1, 2, 3 clinical trials were done on the vaccine that was developed in Serum Institute in India, with the help of multiple partners, including CBER, that is US FDA, WHO, and also with funding from the Gates Foundation. The trials were successful. The vaccine was found to be very good. The vaccine got regulatory approvals, WHO pre-qualification, and then in 2010, the vaccination started in 3 countries, Burkina Faso, Mali, and Niger, for the 1 to 29-year-old population. So obviously adults were part of the vaccination. This was the day, and all the big people were present for the official launch in those countries. And so over the period of next 7 years, multiple campaigns happened across the belt. Across the belt, right? You can see on the left side the countries where the campaigns happened. And so 2010, 19 million doses were used. And by the end of 2017, 277 million doses. So many people got, actually almost 300 million people got the vaccine. It is called as Menafrivac, right? And what, so you can see the effect of Menafrivac. Pre-vaccination, the carriage of the meningococcus A was very high in those regions. After the campaign, the carriage went to 0, right, in the nasopharynx. And what it was found that the herd immunity actually resulted in a major public health success. Meningococcus A was eliminated from the meningitis field. It is estimated that up to 500,000 meningitis cases, 50,000 deaths, and 60,000 cases of severe disability were prevented. And there were huge cost saving because those epidemics really vanished. And now Menafrivac has been included in the EPI of some of the countries. And now Serum is also working on a multivalent conjugate vaccine against ACY-WX. So that was a great public health success story that came from India and had such a positive effect on African continent. Another story is, of course, more recent, and many of you are aware. It's about COVID-19. The pandemic was declared on 11th March, and of course, you know the devastation it caused. And at that time, what was required was safe, efficacious vaccines, which were tested appropriately, met regulatory requirements, right? We don't want a fast track approach just because we wanted to cut corners or take shortcuts. All of this was required. High standards of science, regulations, ethics were required. And at the same time, large production capacity and affordable prices were key. so as to vaccinate the entire world, right? The demand, the requirement was humongous. And again, the Indian manufacturers rose to the occasion, and you had several Indian vaccines that got tested, clinical trials happened, and then they got approvals. Serum Institute, of course, came out with 2 vaccines, Covishield and now Covax. Bharat Biotech with Covaxin, Dr. Reddy's with Sputnik, Zydus Cadila with Zycodi, and Biological E with Corbevax. Right, so you have multiple options now. On
2 minutes more,
3rd
sir.
January, sorry?
Sir, 2 minutes more. Sir,
Yeah.
2 minutes more.
And so we got regulatory approval. Got it.
Oh, yeah.
And these vaccines were used across the world. And as you can see under the vaccine Maitri, these vaccines were supplied. And as I said, 2 billion doses of the vaccines from Serum Institute were supplied to different countries. And because of different vaccines, we know that polio is eliminated, tetanus, maternal, neonatal tetanus eliminated, measles is on the verge. And we can see that the incidence of vaccine preventable diseases is on the decline. Infant mortality rate in India, as you can see, was 200. Now it has come down to below 50. The under 5 mortality rates have gone down. Globally also, you can see that under 5 mortality, infant mortality rate, neonatal mortality rate are going down. And all this is not obviously because of vaccines, but vaccines have played a big role in reducing the infant as well as under 5 mortality, as well as many other diseases. And among the vaccines, because Indian vaccines were at the forefront, they have played a big role. So to conclude, India has a long history of vaccine development. Several companies have made significant contribution in global supply of vaccines, and also meningitis A elimination in sub-Saharan Africa and COVID-19 pandemic. Indian vaccines have been at forefront again, and the vaccines from India continue to play a big role in global public health. So that's all. Thank you very much for your attention.
Thank you, Dr. Kulkarni, for your excellent deliberations. And being Indian, we also feel proud that you were involved with manufacturing of so many vaccines, and you are supplying this India make vaccines to so many countries, including UNICEF, PAO, and many other countries. We really feel proud of that. So please be with us for a few minutes more. We'll take off if there is any questions after this session is over.
Sure.
Thank you, Dr. Kulkarni, sir. So now we pass on to the, next next topic. So the eminent international speaker, that is Dr. Ozden Gogdemi. She has graduated from the Faculty of Medicines of Koradeniz Technical University in 2002, and she spent 2 years in Trabzon Villages Family Welfare Family Healthcare Center, and another 2 years in an emergency unit, rural part, on ambulance or center for emergency. That is, she was attached for at least for 2 years. And she then spent roughly 5 years at Regis Cancer Early Diagnosis, Training and Education Center, where she focused on breast, cervical and colon cancer screening. Cigarette sessions was part of her professional as well. In 2016, she completed her specialization studies at Dokuj Eylul University, and she has completed her PhD at the same university from Department of Physiology. Between 2016 to 2018, she completed her obligatory services in Sparta. So with this very short, excellent curriculum vitae of Dr. Gogdemi, I invite Dr. Gogdemi to the virtual platform to start his deliberation. Dr. Gogdemi, please. Now this stage is yours.
Thank you very much. Thank you very much. It's an honor for me to be with you. I hope that you can see my slides.
Yeah. Please make it full screen.
Is it okay now?
No, it's not yet full screen.
It is not. Can you see the change?
No, it's not changing.
All right.
Can you make it slideshow? Slideshow.
Please reshare. And
Okay. Now can you see it?
yeah,
Yes.
you can see. Yeah,
Okay.
it's full.
Thank you very much again, and it is an honor for me to be with you. I am now working in Izmir University of Economics Faculty of Medicine as Associate Prof. Nowadays in Turkey, it's been saying that it is not a pandemic, it is just going to an endemic. But when we look at the literature, evidence-based literature, we can just say that it is not having finished yet with the dance with COVID-19. So let's put a little bit before the date. Let's just choose a little bit more duration for us. Remember, this is a picture from a cyclopion. A cyclopion is also the place that Galen is working. Galen is also a forgotten master of a cyclopion, because in the cyclopion it's written that that couldn't come here because of the good medicine. The wound was very important for them at those times. There were lots of gladiators, and Galen was one of them. That there were less of that from those fights, and it is because of the sepsis and the wound care. It is important that at those times, Galen also has said that a motto that you should also protect and save your enemies too, not only the ones who are just from you. For this reason, I just begin with Galen, because on vaccination, on COVID, and so communicable disease or non-communicable diseases, this could be the philosophy of us. And Galen just made it, and it is just near to my country, Izmir, in Turkey. And just remember that. Now let's put the time again. We may say that where the vaccination idea has just come from. How can we do that? Let's remember. And also with COVID-19, we have got some products to prevent us. Also, there's garbage from that. And this is another problem for this, for our planetary health. Then the vaccination time has begun. As you may remember, there are some ways that we can use the vaccines. For example, the using of mRNA, and BioNTech and Pfizer and Moderna have just used that. The other is the S proteins. So Johnson & Johnson and AstraZeneca has used this. And another way is recombinant antigens, as the Novavax has used this. What happened in Turkey? As you see, the first cases has been confirmed. It is important that this is the ones who are just said from the government. Maybe there are more before that, but these are the ones that we surely know. What was the point? It was interesting that now we can travel all around the world. It is much, if you have got money and opportunity, you can do that. So also the agents can do the same thing for the contagious diseases. And with that, it's all begin to just work out. We may say that COVID-19 is just make us to see where were the wrong parts, where is the chains are not working in our system for not only the security system, but also the health system. What happened with the family physicians? The family physicians are just worked in COVID-19 clinics for triage and transferred hospital emergency services, and so burnout and being victim of the violence at healthcare services was one of them. And what a pity that there's no vaccination about that. And the misinformation is another thing that we should deal with for the vaccination and also to manage the disease. In here, to get true knowledge, government has just used some of the websites, and also it has been used for the vaccination too. And the Association of the Family Medicine could use the same way as I shared on the screen. And also the Association of Turkish Physicians has shared some of the views from that, and they are going on. First, there was Sinovac when we talk about the vaccination, and it has just begun with Sinovac. And then Pfizer and the BioNTech has begun in Turkey. So there were two options. As you may remember, Özlem Türeci and Uğur Şahin has just made that. Afterwards, Turkovac is one of the product that has been made in Turkey has just come out. So we have got 3 types of vaccine that could be used in Turkey. But which ones we're using in all the countries as has been presented before? As you may see, Oxford AstraZeneca is the ones has been used mostly, and Pfizer is the second one. Sputnik has been told about to distribute in Turkey, but we haven't seen that. At the very first sight, it has been just made step by step. Healthcare workers, elderly people who are working who are just staying in nursery homes, and the ones who are just worked with them has been the first place at the first step. Then at the second part, now we have come to the soldiers, or the people has to be just faced with the communities are the second one. And for the third, the people who have got no chronic diseases and who are just between these years has been just told, and the mask was mandatory at those times. But the fourth is very interesting. There were people who just didn't use this opportunity, or maybe they were ill. What was the point? These were the fourth stage for vaccination in Turkey. So in here we may see that, please forgive me, this is in Turkish because Turkish Association of Physicians has been reported. I didn't want to change anything. As you may see, the blue ones are the vaccination rates that has been made, and the orange one is the ones who has just been vaccinated at the very first time. We may see that it is just going good in some way, and then the vaccination rates has been just stopped. These are the places that when the government was trying to get more vaccine at that time. So stock and management in the healthcare services was another question for that kind of vaccination. But why is this a problem? Because Turkey wasn't a member of COVAX 2, so it couldn't be an option for that time. Although it was a good initiative to just reach the vaccine for all. And also this made another thing that I am thinking about, Galen, just to treat everybody. If you are just treating only the ones who are just much eligible, how can we talk about that everybody is safe? What kind of justice are we talking about if it's nothing to do with the equity? And the other point is vaccine hesitancy. Maybe we have got the vaccine, but people wouldn't like to just make it. Also, this is a public that has been presented before COVID times. As you may see at that pyramid, there's nothing changed for the logical mind. So, World Health Organization just says that the people who are being vaccinated, as you may see, there are some people, mostly in Africa, has got less privilege for that reason. So the truth is, whole world is not safe at the time. What happens in Turkey? As you may see, there are more than 50% of people have been fully vaccinated, and there are also ways that we should just go in Turkey. And this is another presentation for the fully vaccinated ones. Why I just use the fully vaccinated ones? Because some of the people has got the one faster but didn't get the second one. But when we are making these vaccinations, the other part is just the mutations. And also we can say that in Turkey it is Ramadan, and the person has got pide, it is a national part of it, because that means the bread and that means salary. If people hasn't got anything, if the economy is bad, they should just work for it. And maybe this is the way they should just do that. You can't be on quarantine or anything else. So pandemic became a symptom for most of the people. And another part is the violence. As you may see, a year ago, maybe people were just saying, oh, how wonderful it is just to work with us heroes for healthcare. But afterwards, it just became another burden, just as you may see, the violence. And we should deal with another thing. Omicron has gone, and what about long COVID? So the truth is pandemic hasn't just gone again. You may remember the words of Nietzsche. It says that what doesn't kill you just make you much more strong. But the truth is, in virus, it just mutates and tries again. So for the vaccination story, it will go on with the mutations and the new products. Let's not forget that even the dark night will be in an ad if we just work together and just think about the health for all, if we can do that. But for health for all, we just need planetary health too. Not we are talking in global, but not a global village maybe, just to talk and think about each other too. And this is a very important day in Turkey. It is a national day for ourselves. It is a children day because Mustafa Kemal Atatürk has just said that National Sovereignty Day is also a children's day. Sovereignty is just really important for all the nations. And I just want to finish my words when we are working and trying to survive in our world with COVID-19, and some of the people are just at war. So peace at home and peace everywhere should be our motto, and we will need collaboration for that. So 1 minute for our planet is important. And thank you very much for listening to me.
Thank you, Dr. Gogdevi, for your very excellent deliberation. We are really happy that Turkey has already completed almost 62% vaccinations. In our country also, we have covered more than 50%, though we are the second largest, so we are really facing challenge, but our vaccination program is also going with the help of Dr. Kulkarni and many others. We are going also very fast. So really, it's a very excellent deliberation, and you have said a very important statement in your slide, that is, no one is safe until and unless everyone is safe. So it's a very important that is to be kept in mind. So please stay back for a few minutes more. The last speaker, another eminent speaker, is with us. After that, if there is any question, we will take up the questions in question answer session. So please stay with us for a few minutes more. So, namaste. So now we pass on. Namaste, Dr. Rewari sir. So now, now we pass on to the next topic, and that will be dealt with none other than Dr. Aditya Das. She's very, very renowned and important faculty in community medicines of Medical College, Kolkata. She's a very popular teacher. She has so many national and international publications in various important index journals. So with this short introduction, I like to invite Dr. Aditya Das. Now she is faculty in Medical College, Kolkata as assistant professor and working in community medicines of Kolkata Medical College. So I now invite Dr. Aditya Das to start his deliberation.
A very good afternoon. Thank you for a nice introduction. Am I audible to everybody?
Yeah, you are absolutely audible, Dr. Das.
Without much ado, I would like to start my presentation. I have kept it simple, as you have already mentioned. I principally take pleasure in teaching young medicos, so I generally prefer keeping everything simple. So starting the screen share. Is my title slide visible, sir? Is it visible, sir?
Yes, yes.
Dr. Aditya, it's absolutely visible.
So, as we have already been listening so much about pandemic, it is no secret that in this raging pandemic, while we have lost uncountable deaths, we have lost innumerable people with family losses, colleague losses, but the other diseases have really taken a back step. We have been so concerned with dealing with this new challenge that we are almost forgetting that there are other life-threatening diseases as well, and those diseases, they will not go away. They have not been going away since the past century. So rheumatic fever is one such, which is actually, it's a communicable disease, but it can produce rheumatic heart disease, which is one of the most common heart diseases in the young adults and children. So our topic is rheumatic fever, whether it can be eradicated by vaccinations. Now, brushing up a little bit about the current scenario in rheumatic fever. In developing countries, the incidence is more than 50 per 1 lakh population. In group A, Streptococcus hemolytis is the main pathogen. It gives rise to 30% of all the sore throat cases in children, that is age of 5 to 15 years. While it is endemic in sub-Saharan Africa, Middle East, Central and South Asia, Southern Pacific, but there are pockets of poverty in even most developed countries where rheumatic fever is still a cause for innumerable children growing up and having rheumatic heart diseases. About 0.3 to 3% of all group A Streptococcus pharyngitis get rheumatic fever within 2 to 3 weeks, and almost 90% of acute rheumatic fever may have carditis or subsequent rheumatic heart diseases. I have shared a small cartoonized picture of the sequelae of the disease. Moving on. Globally, around 2.8 lakh deaths occur annually. It's most common in low and middle income countries. Most commonly acquired heart disease under 25 years of age is rheumatic heart disease. And among pregnant women, especially in endemic regions, it is the most common heart disease leading to death in pregnant women, leading to mitral stenosis, mitral regurgitation. In India alone, the prevalence is 0.9 per thousand in the 5 to 14 year age group. And annually, approximately 2 million cases are found. But all these data are only tips of the icebergs, because there are many cases of silent rheumatic fevers which don't even come to our attention until it is too late. Rheumatic heart disease, as we all know, once it has progressed to the stage of rheumatic heart disease, it is incurable. Then only tertiary prevention management can be done. So what about the primordial prevention? Improvement of the socioeconomic status, housing conditions, eradication of poverty, access to healthy habits, and more healthcare facilities, healthcare services are some of the important modalities. But in a country like India, or most countries where the disease is endemic, it is very difficult to achieve because of the resource constraints. So next we turn our attention towards the primary prevention. Primary prevention is done by antibiotic treatment of proven or presumed cases of group A Streptococcus pharyngitis. Most patients of rheumatic heart disease are quite late presenters, so even antibiotic therapy are not appreciably beneficial. Now, going on to the secondary prevention. However, the secondary prevention can only be done after the damage is already being done. So in that case, it is highly financially cost effective, and also most of the victims, their quality of life is grossly reduced. Now, we have seen that in Auckland, New Zealand, school-based programs have been set to diagnose and treat pharyngitis, but the incidence of rheumatic fever had not decreased very much. Also, they were seen that the acceptance of it was quite low, and the utility as a public health program was therefore questioned. Empirical single dose IM penicillin to all pharyngitis cases is not cost effective anywhere, particularly with so much of our attention going towards the recent pandemics. Now, 1/3 of the patients, as I have already been talking about, who develop rheumatic fever, they do so after asymptomatic group A Streptococcus infection. So how to treat them with antibiotic if there is no symptom? Now, with all this in mind, the need of the hour is an effective vaccine against group A Streptococcus, and a vaccine that can work towards eradication of rheumatic fever or rheumatic heart disease, and it is the absolute necessity of the hour. Now, we know that Philip Gomez defined vaccine development as the process of taking a new antigen or immunogen which is identified in the research process and develop this substance into the final vaccine that can be evaluated through preclinical and clinical studies to determine safety and efficacy of the resultant vaccine. So this is something that is known to everybody. There are eminent, all participants are eminent and they are experts in this. I'm just revising it. So before vaccine development, like all other vaccines, say it is for COVID vaccines or it is for rheumatic fever, the considerations have to be made for safety, efficacy. Obviously, the cost of development and manufacturing are perhaps the most important issues. And again, in a country which is as widespread as India and with a widely dispersed and diverse population, transportation and storage costs are to be taken into account. The ease of administration is required because in a country like India, the number of beneficiaries with the ratio, if the ratio is computed with the number of trained vaccinators, it could be less. Now, the number of doses required for adequate protection is another consideration because with more number of doses, obviously the reception of the vaccines become less and less. And lastly, duration of immunity and the requirement of the booster doses are other considerations that are effectively involved with vaccine development. Now, we all know that the primary steps of vaccine development are the exploratory stage, which is the research. But while doing this topic, while searching for this topic, I found globally the research or the interest in research regarding vaccine development of rheumatic fever is very little. There is also the preclinical stage in which animal models are tried and tested, which is also I didn't find adequate data. The clinical development, which we proudly call as vaccine trials, there have been few, which I will come in due course. Then the regulatory review and approval, manufacturing, and lastly quality control. But these issues are far in the future because we have not yet achieved till preclinical stage in most of the vaccine trials. So, whether the vaccine for rheumatic fever are myth or reality. Historically, researches have been started from 1960 and the target was the cell wall to M protein of group A streptococcus. But yet no vaccine has been proved to be effective. Why so? Also, it was seen that globally in the developed countries, the prevalence became as low from 9.5 per thousand population, it has reduced to almost 4.5. That is, it is halved. But it is not so in the developing countries. Also in developed countries, the minority populations, the poor populations, the marginalized populations, and the victims of any kind of war or any kind of transfer, any kind of migration are still widely under the problems of rheumatic fever. But there hasn't been a single vaccine which could be address their issues. Now, what are the possible causes of the researchers that failed from 1960 onwards? There is widespread diversity of the M gene type encoding M protein. At around 250 such M gene types have been found out. There is cross-reactivity between streptococcus and host proteins. Those result in adverse effects. And we are yet to find out all the rheumatogenic strains. Also, group A streptococcus have a tendency about rapid mutation and molecular mimicry. Strains vary from place to place and also within the same community. Lack of animal model is there because man is the only host of rheumatic fever, so we are not yet fully understanding the pathogenesis in the other animal model that we can do for research. Excuse me. The factors other than M protein can be involved in pathogenesis, and other than group A streptococcus, group G streptococcus can also cause rheumatic fever. Now, what is new about rheumatic fever pathogenesis? As I was talking about molecular mimicry, contrary to previous theory that only molecular mimicry between M protein, which contains myosin, and hard tissue myosin, present research identifies some other factors which are implicated in the pathogenesis. The antibodies to N-acetyl beta-D-glucosamine epitope of group A streptococcus carbohydrate are implicated. Collagen type 4 of basement membrane which M protein binds. Antibody cross-reactivity to endothelial antigen laminin in the heart tissues, and the T helper cell infiltration in the cardiac valves causes scarring.
2 minutes more, Dr. Das.
Yes, I'm aware, sir. Possible ways to develop a vaccine are the vaccine targets for Streptococcus pyogenes, which are targeted on cell surface proteins, on secretory proteins, and on carbohydrates. Now, regarding cell surface proteins, the targets are M protein, both N-terminal and C-terminal. C5a peptides are also targeted. Fibronectin binding proteins and cell envelope proteins are also targets for cell surface based proteins. Regarding secreted proteins, the pyogenic strains that produce exotoxins are converted to toxoids. 11 such strains have been identified and they show considerable promise in the mice models. Regarding carbohydrates, there is some concern regarding cross-reactivity with neuronal tissue of host. So the vaccine trial is under question right now. Now, there are some future perspectives as well. Computational methods are now being employed to screen all the proteins encoded by the pathogen, and the novel proteins that will be encoded by the genome can act as vaccine candidates. After cloning and purifying these proteins, animal experiments are conducted to look for protective immunity. This is sometimes referred to as reverse vaccinology. Recently, it is seen that a 30-valent vaccine based on M protein, which are shown to be protective against rheumatic heart disease in developed countries, are undergoing clinical trials. Other vaccines targeting different antigens are also in the pipeline, but promises are yet to be fulfilled. So, to sum up, I can say that research is ongoing to develop a unique and cost-effective vaccine that protects against all the strains of group A Streptococcus. Identifying the novel protein implicated in the virulence and uniformly present in all the strains is now of primary importance. Until and unless such a vaccine is widely available and extensively studied, eradication by primary prevention has to be waited. So, all of us are eagerly waiting so that in near future an effective vaccine against all the group A Streptococcus strains or group G strains are available to us so that we can finally eradicate this disease from our country and globally. Thank you.
Thank you, Dr. Aditya Das, for your very excellent, lucid, and informative lecture. Now, the session is open to everyone. If there is any questions from our distinguished panelists, you can ask directly, or I will go for the chat box whether there is any question or not. Still, there is yet to get any questions on these three topics. So every speaker has done their job excellently. We have really learned a lot from their lectures. And a very short question to Dr. Kulkarni. That is, Dr. Kulkarni, what do you think within a minute, are we going to face the end of COVID-19 in recent future? Probably he's offline. So,
sorry,
okay.
Dr. Karmakar, I couldn't hear your question.
No. Can we expect that within in recent future we are going to make an end to COVID-19 globally? Very short answer. What is your expectation?
Well, yes and no, I can say. The answer is very difficult to give.
Right.
Chances are
Right. It's very difficult to say. Probably he is offline again. So, Dr. Godkevit, may I know which one is the most common vaccine is being used in your country?
Now, mostly Sinovac and Pfizer, but Chronovac is also the truth is Trucovac is just being used in family healthcare centers too. For Sinovac, it is being used that too. So we are just keeping on vaccinating.
Okay. Thank you.
But
so
we haven't got Sputnik, for example. Thank you.
Thank you. So if there is no more questions, I wish everyone excellent deliberations by all of you. So I'm really thankful to all of you. Please stay back. Please stay with us for some time more. So I hand over my digital platform to Dr. Rivi Vasu for the next session, please.
Thank you,
Professor
Dr. Rivi
Karmakar.
Vasu.
And it was a very enriching session for all of us. And hopefully all the audience will be gaining immensely from this. And we have also have got the recordings in the YouTube, so you can log in later also to have these recordings and share it with your like colleagues and your students. With that, we can call this session an end, and we can directly go to the next session because we are running slightly short of time. And the next session is on HIV and Shankar. So for this session, I am introducing our dignified chairperson, none other than Dr. Sharup Sarkar. Sir, please you can switch on your video and Dr. Sharup Sarkar, please.
Yes, I've switched on my video. Please go ahead.
The speakers, can you please switch on your videos, please? Speakers for the next session. Professor
Dr. Rewari has already joined. Professor Rewari has already joined. The first speaker.
Dr. Aryan Basu, are you here?
No, Dr. Shantan, Dr. Chaitanya Patil.
Dr. Shantan? Dr. Shantan, are you here? Dr. Shantan, okay, we shall call him. Dr. Rewari is here, right? So, yeah. Right. So, I have got this wonderful privilege of introducing to all the audience Dr. Sharup Sarkar, an experienced and strategic global health diplomat and practitioner with wide-ranging expertise on global, regional, national policy and programmatic approaches to addressing outbreak control, disease eliminations, with experience and interest in understanding and engaging affected communities in the formulation, implementation, and governance of health programs. He has served UN for 2 decades, and after his retirement, his focus is on currently working on advising governments, multilateral bodies, and community organizations on COVID-19 and eliminating communicable diseases, with special reference to marginalized people, evidence-based response, and south to south as well as north to south collaboration for better public good. He began with teaching in medical school in India, developing curriculum, teaching and training for more than 2 decades. And that has been a part of his career, spanning global, regional, and national programs in health and ranging epidemiology, statistics, health economics, development of survey tools and softwares, and diverse training and teaching materials for various cultural, political, and health settings. So, welcome, Dr. Sarkar. I am handing over the stage to you.
Hello, good evening, and good afternoon, and good morning, depending on which part of the world you are. And thank you everybody for joining such a very important session. And many of you may or may not know that adult vaccination and immunization, particularly in India, has been a very, very neglected subject for many years. While many clinicians and epidemiologists like me see cases of adult diphtheria, adult pertussis, we never had a program in India. So that's where this particular organization, which is trying for the last few years to bring adult immunization on board, today is a milestone for not only for this organization, but for rest of us who work in public health and clinical setting to see this very important topic to be discussed and presented. Now, having said this, whenever we talk about adult vaccination, one important question, and which also came in COVID almost on a regular basis, that whether the patients or the persons who are immune compromised should take vaccine or not. Daily we receive questions, even for COVID, whether a person who has, say cancer, whether they would take vaccination. And you and I know that they are the first priority group to have vaccination to reduce mortality. So therefore, 2 important conditions which are very much prevalent in India, HIV as well as cancer. These 2 topics are very much part of this session. where we'll be listening from our esteemed scientists and distinguished speakers about in HIV and in cancer, how far we are in the progress of a vaccine, and whether vaccination, adult vaccination or for other diseases are indicated or contraindicated. Having said this, so we have three speakers. I don't see Dr. Chaitanya. Yes, I see him on the screen. Okay, Chaitanya, why don't you switch on your camera also? And Shantanu, also please switch on your camera. We have three distinguished speakers. First is Dr. B.B. Riwari. Dr. Riwari is the Chief of HIV, STI and Hepatitis in Southeast Asian Regional Office of WHO, which looks after 11 countries of this region, almost 16% of the global population. Now, he's working on HIV for the last almost 25 years. Correct me, Dr. Riwari, if I'm telling wrong. And then he has dedicated his life, and he's one of the few people who is fully working on seeing hepatitis as an eliminable disease in a short period, So having said this, Dr. Riwari, he doesn't, many of you know, he doesn't need much introduction. He has all possible degrees. Once you see the brochure, you will see he has both fellowship and as well as postgraduate degree from India in clinical medicine, and he has been one of the very renowned and well-respected clinician as well as public health specialist, particularly on HIV. So, Dr. Riwari, over to you. You have 15 minutes, but if you could keep it even shorter and keep question answer earlier, that would be better. Now, can you start your presentation on HIV vaccine? How far are we? Over to you, Dr. Riwari.
Good morning, good afternoon, good evening, everyone. Thank you, Dr. Swaroop, for your kind words. It is always a pleasure.
Sir, can I just interrupt? Sorry, sir.
Yeah, please.
Can you please make it a full screen mode so that it is easier for our spectators?
It's not full screen right now.
Okay, sir. Just click the three dots. Okay, hide the and you can hide the presenter view. That will make it full screen, sir.
Okay, fine. It's full screen now?
Yes, sir. It's full screen now. Thank you.
Go ahead. Go ahead.
So thank you, and a big thanks to organizers for giving me this opportunity to present on HIV vaccine. How far are we? This has become very relevant with the COVID-19 vaccine being made available so quickly after the organism was identified and people had different kind of presentations, and pandemic of COVID-19, we were very quickly able to develop a vaccine. So naturally, the question is coming back, why we have not been able to develop HIV vaccine so far, and whether the learning from COVID-19 vaccine will really help in developing a vaccine for HIV also. We know that we are aiming for end of the AIDS epidemic by 2030, and we know that we had different phases of this epidemic, and now we are in the last phase, that is last decade, where we aim to end this epidemic as a public health problem. And there are many ways, and one of the ways to scale up ART to all to prevent transmission. I know Dr. Swaroop will not agree with me on this, and I also fully do not agree, but this is a major scale up of antiretroviral therapy that can help in reducing transmission and not ending epidemic as such. We also need to focus on all biomedical prevention tools, the newer tools, particularly the pre-exposure prophylaxis in form of oral intervention, vaginal rings, long-acting injectables, cabotegravir, rilpivirine coming in. We also have some hope from HIV cure research with 2 patients being cured, but that not being a very practical approach, but that also offers a approach into the vaccine development also. So that is why it is very important that we are not on the track to meet the global target of 2020. So it is very important that we really need to have a HIV vaccine which is safe and effective. There could be 2 types of HIV vaccine broadly. Preventive vaccine are designed for those who are not infected with HIV. They can just teach the immune system to recognize the virus right away and block it from causing infection. Therapeutic vaccine are designed for people who are already living with HIV. they can strengthen the body's immune system to control HIV in addition to antiretroviral therapy or even without antiretroviral therapy. But the focus presently is more on preventive vaccine rather than therapeutic vaccine, because a preventive vaccine basically would carry or induce a production of component that looks and feel like a part of HIV, and then body would react by generating immune response. The whole virus is not used, neither killed or weakened, so HIV vaccine cannot cause HIV infection. There are different vaccine development approaches which are used for HIV also and others also. And these include, we know, DNA-based vaccine, RNA vaccine, inactivated vaccines, subunit vaccines, and live attenuated. But the focus currently is basically now moving to messenger RNA, broadly neutralizing antibodies, and replicating viral vectors in terms of development. Why the approaches have failed? We know that HIV is hypervariable. You can always say that COVID-19 has more variants, but yes, HIV, if you go into their subtypes and further tree, there are much more variant in HIV also. And once HIV infects a person, it maintains the infection for whole life. So there is no natural immunity from reinfection. HIV virus also evades and escapes from antiviral bodies and T-cell responses because it directly infects and attacks the CD4 cells. So the virus is silent. It does not provoke an effective immune response. The antibodies that we detect with the test are basically too late or too specific to stop infection. It is shifty. It challenges all the time. It is challenge and changes are much faster than flu or COVID. And this means by the time antibodies are developed, it is mutated beyond them and they're not very specific. And it is subversive also. So this is an overview of what has been vaccine trials so far. There have been 6 phase 2 or phase 3 clinical trials which have been completed since the discovery of virus in 1981. And if you see the one in the box, RV144, I'll go a little more into details of this because all other trials, that is AIDS trial in 2003, STEP trial, HVTN 505, they did not have any efficacy. Only trial which showed some efficacy was RV144, and this trial was done in Thailand, and it showed almost 60% efficacy at 9 months. But over the period of time, after 3 years, the efficacy was just 31%, which is just statistically significant. So the antibody response was very specific and particularly against the weakest tier 1 virus among the low risk population. Moving ahead, there were a number of other trials in different population among MSM, among heterosexual men, among transgender women, and these were differently done in different countries in 2008, 2011, and even 2013. All these trials are named as HIV vaccine trials, HVTN 502, 503, 505, they are numbered. But if you see in the bottom, there was no efficacy for the 502 and 503, and rather there was an increased risk of acquisition in the vaccine group. So all these trials were stopped in between. Even HVTN 505, there was no increased risk, but there was no efficacy again. These are some of the trials that are done in recent past, that is 2020. This is a trial 702, and this was a lengthy development process. The design was similar to the Thailand trial, that was RV144, but this was adapted for South African viral subtypes. And this was done in almost 5,000 men and women. But again, this was stopped after the Data Safety Board reviewed this in January 20, that there were 129 infection with vaccine versus 123 with placebo. So the trial was stopped in between. But there has been learnings through these failing trials. All trials teach some lesson that we are failing because we are targeting a specific protein in the virus. So there were 2 more trials which have come on basis which are called Mosaic Vaccines. And these Mosaic vaccine has got multiple, if you see on the right side, they've got different chains of natural HIV proteins, and they are integrated into one vaccine. And there are 2 trials being conducted with Mosaic vaccine, that is HVTN 705 and 706. These are called Imbogo trial and Mosaico trial. Again, if you see the details of this trial 705, this was done at 23 trial sites, administered through 4 vaccinations over 1 year, and primary endpoint was HIV infection at the month 7 and month 24. But again, if we see, the efficacy was 25% only. the study was not decided. It was decided not to continue because the protection was not sufficient. This is the trial which is still ongoing. This is the only current phase 3 trial. This is using a recombinant of AD26 and subtype C and Mosaic GP140. This is being done in 7 countries with almost 3,800 MSM and transgender women, which are planned, and this is ongoing. This is the only ongoing trial. Another trial which is in phase 2B, not in phase 3, is PrEP-VEC trial. And this PrEP-VEC trial basically is a combination trial. Patients are randomized to receive a oral PrEP and also one of the 2 experimental vaccines. So it is a combination that they receive oral PrEP over weeks 0 to 26, and then vaccine injections are received from 0 to 48 weeks. The results from this trial are expected in 2023. These are some of the upcoming trials which are in phase 1 only presently. So these are 3 new phase 1 trials which are testing messenger RNA mediated delivery of HIV vaccine. And some of these trials basically are now following what we basically did for COVID vaccination. Another way, not a directly vaccination, but this is a concept HIV broadly neutralizing antibodies. We know this broadly and neutralizing antibodies has been the concept in COVID-19 also. And these monoclonal antibodies are able to neutralize wide range of HIV isolates, and they target the HIV-1 envelope. And this are also used for treatment intensification with concomitant use of antiretroviral therapy with broadly neutralizing antibodies. So these are also going to be a major focus of vaccine design strategies in the futures. And some of the trials basically are now using this concept to look into development of a new vaccine. Little bit about the SARS-CoV-2 and HIV. What are the similarities and differences? Basically, if we see there is enormous diversity of HIV with persistent infection, and SARS-CoV-2 is more limited. We have seen many variants, but if you see the whole genomic structure of HIV and the variants, they are much more. HIV has got high level of glycoprotein in envelope. Glycosylation is limited in SARS-CoV-2. Neutralizing epitopes are structurally shielded by in the HIV while they are accessible to antibodies. So there is a wide diversity, and you can see in the right side there are groups from M, N, O, P. Within M there are multiple subtypes from A to K. While in SARS-CoV-2 there are alpha, beta, gamma, delta, and omicron 30 mutants. So the number is much less in terms of SARS-CoV-2. Also, if you see
Dr. Diwari,
yeah,
1 minute.
Yeah, I'll just complete. So if you see in terms of investment also, there is a huge difference of investment from 100 billions in COVID vaccine candidate to 900 millions for HIV vaccine. So, concluding, vaccine advocacy in 2020 will require sufficient diversified research funding, enhanced global coordination and collaboration, support for research innovation and novel trial designs with a strengthened political commitment. We need to place community at center of vaccine research and plan for early success and equitable success. So I'll just not go to HIV cure, but just summarize that repeating again, there is extensive viral clade and sequence diversity, latent reservoirs, and viral evasion of humoral and cellular immune response, which are actually stopping the development of a good vaccine. These are some of the summary of the vaccine studies. And lastly, we need to translate these concepts from lab to clinic to have a global impact, and we'll need more of a combination with broadly neutralizing antibody, antiretroviral therapy, and maybe a therapeutic vaccine. Thank you so much.
Thank you, Dr. Diwari. It was a very nice, informative presentation. And now I think we'll come back to the question at the end. But if somebody can, finish early, they can take the question early. So over to Shayantan. Shayantan is one of the very promising young microbiologist and a clinical ID specialist who has a postgraduate and super postgraduate degree in microbiology and then clinical ID. He is now professor at All India Institute in Kalyani. And then over to Shantan for your 15 minutes talk on, and I'll request if you can shorten it, we can take questions. Adult immunization in HIV positive patient. Over to you, Shantan, please.
Good evening. Thank you, Dr. Swaroop. I hope I am audible and my screen is visible. Thank you so much. So we'll be dealing with immunization of people living with HIV and AIDS in a very short seminar, in a very short talk. So basically the general principles for immunization of adult patients with HIV is that most of the data in vaccination shows that HIV patients have, actually, they have seen the immunogenicity rather than clinical efficacy of most of the data that we have for vaccine studies. Now, definitely the vaccines tend to be less immunogenic. And as we were seeing the data were before the advent of integrase inhibitors in the common HIV programs. So whatever data we have now are the data which was generated before dolutegravir was brought into the program massively. Okay, and it was before in large countries where which adopted universal treatment for HIV on diagnosis. So there are studies which have shown that many vaccines are less immunogenic and antibody responses were actually short-lived in the setting of HIV infection. But it has been seen that if the vaccines are given early in the infection, before the CD4 cells have significantly fallen down, or if it is given after the immune reconstitution, then probably the vaccine is more immunogenic and the antibody responses are longer lived in the setting of HIV infection. Inactivated vaccines, as we know, are generally safe and acceptable, and most of the inactivated vaccines, for giving them, you do not have to wait for immune reconstitution. And many of the inactivated vaccines achieve, not only inactivated, many of the vaccines achieve protective immunity quite well, particularly nowadays when we are having good therapy and viral suppression is significant. Most of the vaccines achieve quite good antibody levels. Certain live vaccines also have sufficient safety data on HIV patients, particularly the HIV patients who have more than 200 CD4 count. So if patients have less than 200 CD4 count, and for kids, for the children, if the CD4 percentage is less than 15%, we generally do not recommend live vaccines. Okay. Now, if you see the list of the vaccines, all adult HIV patients must receive a few vaccines. Number one is the COVID-19 vaccine. Now, regarding the COVID-19 vaccines, the vaccines that are available over here at present, all across the world, are the mRNA vaccines, the live vaccines, which are not replicable, and the inactivated vaccines. None of the vaccines have been shown to pose a significant threat for HIV patients. Inactivated seasonal influenza vaccines, the quadrivalent vaccine that we have, not the live one. The diphtheria, tetanus, and Astellula pertussis vaccine nowadays, most commonly reported from Europe, less commonly reported from India, but it has been started being reported from India as well, that adult pertussis is becoming a significant problem. So in HIV patients, Tdap is recommended for all HIV patients. HPV vaccines, if not received previously, up to the age of 26 years. Now, the comment related to this 26-year age is that, the comment that the 26 years age is just because it has been the capping age of most of the trials. But it need not be 26 years. There has been studies which are studying people who are at risk of HPV-related significant malignancies like MSM and commercial sex workers, it is nowadays being recommended that even above 26 years, HIV patients may get HPV vaccines. Regarding some other vaccines for which HIV itself is an indication, otherwise in general adult population you may not give, is pneumococcal vaccination, hepatitis A and hepatitis B vaccination unless the patient is already immune, and meningococcal vaccination. There are certain vaccines which the AIDS patient can additionally receive, like Haemophilus influenzae B, but not for routine patients, only in case there is asthenia. MMR, varicella, these two vaccines are live vaccines. They can be given to HIV patients if the CD4 cell counts are more than 200. You cannot give it if those are less than 200. And you can actually test the titer level and see if they are already immune. If the IgG levels of measles, mumps, rubella, and varicella are already high, we may not give MMRV vaccines for HIV patients. Regarding inactivated zoster vaccine, it does not have any extra risk of, varicella or zoster because it's an inactivated vaccine. And for all HIV patients above 50 years of age, inactivated zoster vaccine is recommended in most of the Western and US guidelines. So regarding COVID-19 vaccines, as of now, the benefit outweighs the potential risk. And as I was telling, that though the immunogenicity may be lower, but still, there is significant immunogenicity found in many of the studies. Overall efficacy and safety has not been determined, but the vaccines that are readily available right now, the mRNA vaccines, the Covaxin, that is the inactivated vaccine, as well as the AstraZeneca vaccine, which is live but not replication competent, they can be used safely for HIV patients as of now. Regarding Tdap vaccine, all the HIV positive patients should get one dose of tetanus reduced diphtheria and acellular pertussis vaccine. All the HIV pregnant women must receive one Tdap vaccine every time in pregnancy. Regarding the pneumococcal vaccines, all the HIV positive patients should get at least one dose of the pneumococcal conjugate vaccine. It is said that for the different immunocompromised group of patients, if you add up with the polysaccharide vaccine, that is the Pneumovax, after Prevenar, after the PCV conjugate vaccine, with at a gap of at least 8 weeks, it is a prime boost strategy, which makes the immune response more, more sustained and more protective. It is seen, however, that if the CD4 count is more than 200, then the polysaccharide vaccine's immune response is better. So it is said that you give the PCV vaccine as soon as you get the HIV patient. But when immune reconstitution occurs after giving ART therapy, then when the CD4 rises above 200, you follow up with the polysaccharide vaccine. When the cell count, the CD4 cell count is less than 200, we give cotrimoxazole for pneumocystis cerevisiae prevention, which actually prevents against pneumococcal severe disease as well. Regarding hepatitis A vaccine, previously it was recommended that people with HIV who has chronic Hep B or Hep C, they should be given hepatitis A so that there is no further insult on the liver. And people with injection drug users and MSM population and homeless population were previously advised to get hepatitis A vaccination. But nowadays, hepatitis A vaccine is being recommended for all patients with HIV. Particularly, it has been shown in different studies that if we screen for hepatitis A antibodies before giving the vaccine, probably it is more cost effective. And in our country, where the prevalence rates are almost 90%, above 40 years of age, here you may not need hepatitis A vaccination if we can do screening for hepatitis A antibodies. Regarding hepatitis B vaccination, all patients at HIV are at risk, increased risk for hepatitis B and C as well. And as we know that hepatitis C is a completely treatable condition right now, and we don't have a vaccine for hepatitis C, hepatitis B vaccines are recommended for HIV patients. HIV patients should be tested for hepatitis B surface antigen, anti-HBs antibody, and anti-HBC upon a HIV diagnosis. So it is because often the surface antigen can be negative, and there can be occult hepatitis infection where anti-HBC is positive. So if patients who are only positive for anti-HBC, which means there can be past infection or there can be present infection as well, but there is no protective level of anti-HBs antibody, hepatitis B vaccination is recommended. There are increasing number of studies which shows that just like dialysis, if we double the dose of hepatitis B vaccination using the standard regimen, 1 month and 6 month regimen, but the double dose, 1 ml, it is actually much better immunogenic. So for HIV patients, we will use 1 ml of hepatitis B vaccines. Anti-HBs antibody titer can be measured if people do not respond to the first course of vaccination. A second vaccine series is recommended. If the person do not respond to the second series of vaccination, 016, even after the 6th dose, that is the 3rd dose of the second series, then a repeated third series is not recommended. Okay, this is because most of the HIV drugs that we use, particularly for the first line, we are using tenofovir and either lamivudine or emtricitabine. So both these sorts of tenofovir, disoproxil as well as alafenamide, as well as lamivudine and emtricitabine has some action against hepatitis B. So that is one protective factor of the ART. Regarding meningococcal vaccine, actually meningococcal vaccine, US recommendation is that it should be recommended for all individuals with HIV vaccine, which with HIV disease, which has not come yet in Indian recommendations. But if meningococcal vaccines are available, it should be given 2 doses between 2 to 3 months apart. And one point we should remember that this conjugate meningococcal vaccine and the pneumococcal conjugate vaccine, there should be a 4 weeks gap between the meningococcal and pneumococcal conjugate vaccine.
Shantanu, 1 minute.
The last slide. Yeah, the last slide. This is my last slide. This is regarding the 2 other important vaccines. So there was a WHO expert committee meeting which recommended that for rabies vaccination, whenever in India, as rabies vaccination is very important, whenever rabies vaccination has to be given in the 4-site intradermal route, the double dose volume is better immunogenic for HIV patients. So there has been very little scientific evidence backing it, but this is the WHO expert committee recommendation, and the inactivated rabies vaccine do not pose any extra risk for HIV patients, so we can give the double dose volume for HIV positive patients. As I told, that zoster patients, zoster vaccine is inactivated, we can give this non-live zoster vaccine. So there are certain countries for visiting which you need a yellow fever vaccination, which is live vaccine, 70D vaccination. So the 17D live yellow fever vaccine can be given to HIV patients. We often get this query if the CD4 count is more than 200. If the CD4 count is less than 200 and the patient is wanting to travel to a yellow fever prone country, the advice would be against traveling. So this is all that I have to talk about. I'm happy to take questions whenever it is permitted. Thank you.
Thank you, Shantanu. Very good presentation. You also see questions come up in chat box. If we have time, we'll come back to those. Over to Dr. Chaitanya Patil. Chaitanya is one of the bright young physician who also specializes in community medicine and digital medicine, as I can see from his CV, who also has a postdoc fellowship in oncology, and has worked both in family and individual setting, dealing with the cancer patients in particular. Now he will be elaborating on a very special topic today. Cancer, as you know, is one of the immune suppressive condition, but at the same time he will talk about role of immunization in prevention, as well as concept of therapeutic vaccine. Many of you may know this is a complete mind-boggling area and complete new area opening a horizon, particularly with the mRNA vaccine or individual vaccines. But I'll now pass it on to Chaitanya to talk about his topic, cancer's role of immunization in prevention, concept of therapeutic vaccine. Chaitanya, please.
Thank you, sir. Am I audible?
Yes, please.
Yeah. So my today's topic is on role of immunity in cancer and how actually immunity plays a significant role in cancer and what are all the potential targets where we can actually target on conducting preventive vaccines and therapeutic vaccines, which we use commonly in our patients. So to give you an overview, we'll be in these topics. It will be first we'll be covering the role of immune system in cancer pathogenesis and the concept of cancer vaccines. We know there are many preventive vaccines coming up like HPV and hepatitis B, which has been a cancer preventable vaccine. I'll be focusing more on the concept of therapeutic vaccines here. So we know that cancer immunotherapy and immune oncology has been a very rapidly growing branch in the coming in the recent days. Basically, these target on the immune pathways where we work on the immune oncology. 20th century era changed because the cancer treatment and the approach towards the cancer treatment changed with the use of all cytotoxic new drugs coming up and targeted therapies coming up. And there was discovery of nitrogen mustards and many more congeners which actually helped us. So to date back, the first introduction of immunotherapy or what is called as immuno-oncology was done by Dr. William Cooley. He actually did an experiment on the beneficial effect of erysipelas and fever in malignant tumors. And later, after 20 years, after almost 2 decades, Johnson et al. Studied this Cooley's toxin on and established the role of immune stimulating inoculations. So this is the basic historical place where this all started. So we all know that how our immunity plays a role when a non-self antigen actually enters the body. It detects the non-self antigens from the pathogens or the infected or malignant cells. That is the first basic principle. The second basic principle, it encompasses effector functions to specifically target and destroy that infected or malignant cells. And the third and most important thing is it develops an immunological memory by adaptive immune response for subsequent mechanisms or subsequent attacks that happen in the future. This is the basic idea how the cancer biology works. We all know that there are something called as oncogenes or tumor suppressant genes, where there occurs a mutation. These mutations are usually triggered by our lifestyle changes, diet, carcinogens, where they enter into such a phase where the things go haywire, where the overall number of cells starts increasing. With the number of cells, the size of the organ or the size of our organ system starts increasing. Along with that, the body responds with a lot of factors like vascular endothelial growth factor, hypoxia-inducible, transfusible factors, where they need more blood vessels, and with the blood vessels, there will be distance metastasis. So a tumor per se will be carcinogenic or malignant once it starts metastasizing is with the core culture. So these are all some potential targets which we'll be covering. We know how our immunity works, innate immunity and adaptive immunity, where majority of our innate immunity is by birth and adaptive immunity is by the virtue of what we actually gain throughout our life system. So to broadly classify, there are 2 types of cancer vaccines, which are one is prophylactical vaccines or preventive vaccines, where the main target is primary and secondary cancer prevention, where cancer incidence, morbidity, and mortality are the main focus. The second concept is therapeutic vaccines, which are given to treat the existing malignancy as an add-on therapy with the routine chemotherapy regimens or radiotherapy or surgery. So potential therapeutic vaccine targets are some tumor-specific antigens, which are uniquely actually expressed in the tumor cells, or tumor-associated antigens, which are expressed at both at tumor cells and healthy cells, and we try to target them to tumor-specific antigens. Some examples to take in are overexpressed antigens such as mucin A and human epidermal growth factor EGFR among lung cancers and oral malignancies, where we can target a specific vaccine and a specific target chemotherapy regimen for such patients. There are some differentiation antigens such as prostatic acid phosphatase, prostatic specific antigen, glycoprotein 100, and melanoma antigen recognized by T cells, which is called abbreviated as MART1. We also, as I was discussing, vascular endothelial growth factor receptors can be directed and can be a target for improvement of the tumor microenvironment. We all know that this is an era of personalized or precision medicine, actually. So there are many new epitopes coming in. One of the antigens that is on focus in the recent days is of cancer of testis, where they have started including under investigation to like melanoma associated antigen 1 and newer esophageal carcinoma antigen 1 as a focus where they can actually work. On a broader classification, we all know vaccine platforms can be either peptide or proteins, whole tumor cells, recombinant vectors can be used, dendritic cells can be used, gangliosides can be used, and genes can be used. The most common one what we use in cancer vaccines is peptides or proteins. But again, there are some advantages and disadvantages in this. HLA typing is required for such things where a lot of allergic issues need to be handled. And if it is a short peptide amino acid chain, then it is easy to actually manufacture and economical and safe to use. But if it is a long chain amino acid, it becomes a bit tedious and a more costly procedure where we usually end up becoming more costly for the common people. Initially, when the cancer vaccine started, they started using whole tumor cell vaccines. Whole tumor cell vaccines are of two types. One is autologous and allogenic. Autologous are difficult to actually procure and are less feasible. Allogenic, they use it, but there are a lot of immunogenicity related issues. Recombinant vectors can be used where an advantage otherwise to use recombinant vectors, but because of the weak immunogenicity, these are not frequently used. The fourth one, which is important, and one of the classic trial came in on one of the vaccine, which actually used dendritic cells, which I'll be focusing in the coming slides, which was a Provenge trial. And the fifth one is gangliosides. Gangliosides actually are expressed as one of the cancer expressing antigens, where monoclonal antibodies against these gangliosides are used, and that will be a part of the cancer vaccine. Genes can be used if it is a specific targeted therapy, and we know what gene exactly has been utilized. But again, less scope because of its weak immunogenicity.
You have 2 minutes.
Yes, sir. These are some approved FDA approved vaccines. I'll be just quickly going on. One is Therasis, which is has been dated back to 1990, was approved by FDA. We have used it for intravesical tumors, where we used it for urothelial carcinomas. As we were focusing, there is a multi-center randomized open label trial where we found out there was a significant difference between the 5-year disease-free survival of the BCG recipients and the routine chemotherapy regimens. The second one, which I was focusing on, was Provenge, which is a dendritic cell vaccine. I got an FDA approval in 2010. Here, basically, there will be autologous peripheral blood mononuclear cells, which are activated and basically by culture with PA2024. And this fusion protein actually helps in attacking the cancer cells. So it is a costly procedure, but still it is typically effective. Another one to focus on for therapeutic vaccine is TVEC, where the main mechanism of action was to in mediating local and systemic immune responses. These are some recent trials which are going on since 2008 till 2019, but we still have to get some more output of this vaccine trials. We know the preventable vaccines, which is Gardasil, which FDA has approved for 9 to 26 years of age, as like Dr. Saintan was mentioning, for cervical, vaginal, and vulvar cancer, to prevent basically cervical, vaginal, and vulvar cancers, anal cancer in men and women, and genital warts in men and boys. I'll be just focusing on these vaccines, the regimen, where we give Gardasil, which is 0.5 ml, with 2-dose regimen and 3-dose regimen. The schedule is 0, 6, and 12 months, or 0, 2, or 6 months. Cervarix is usually given intramuscular in females from 9 through 25 years of age. The 3 typical doses of 0.5 ml each from 0, 1, and 6 months. So to summarize, there are cancer vaccines to focus on preventive and therapeutic vaccines. FDA approvals, more precise or randomized controlled trials, more precise molecular level studies have to be conducted in a very varied geographical population, so that can help thing. But preventive vaccines have a very good and hope and a promising approach in decreasing the overall incidence of some major cancers like anal, cervical, vulval, and genital warts in men. This is everything from my side. I'm okay to take any questions. Thank you.
Thank you very much. I think, no speaker has left time to go for question answer session, but maybe we just take one question each. If anybody has specific question, can you put on the chat box? By this time, Dr. Riwari may be speaking on, use a viral load now instead of CD4 and use that for, vaccine in HIV positive patient, if any. Then Shantanu can clarify on the surface antigen. And Chaitanya can speak one line on new mRNA vaccines, oncogenes, So, Dr. Riwari, please.
So Dr. Swarup, basic principle is inactivated vaccine can be given irrespective of CD4 count. But for live vaccine, basically it is better in terms of safety if the CD4 count is more than 200. And now coming to the issue of the CD4 count not being done regularly, actually the recommendation from WHO is that CD4 count is not required for initiation of the treatment. All people get treatment irrespective of CD4 count, but still a baseline CD4 is required because we want to classify patients into advanced HIV disease, means those who have got CD4 less than 200. And these are the people who are at risk of dying, and 50% of deaths within first 6 months are among people with advanced disease. So it is important that we still do the CD4 count at baseline, not for initiation of ART, but for additional prophylaxis and also for the issue of live vaccines. So it would be better if live vaccines are given when CD4 count is more than 200, but other vaccines can be given irrespective of CD4 count. Thank you.
Thank you. Shantanu?
So I completely agree with Dr. Riwari's chat in the chat box that in our national program, it is recommended only to do HBs surface antigen, HB surface antigen, and anti-HCV. Regarding hepatitis C, I don't have any comment as we don't have a vaccine yet. And it's a completely curable disease with the directly active antivirals right now. Regarding hepatitis B, actually, even with hepatitis B surface antigen, there are a lot of flaws. I was just trying to write in the chat box. Because, whenever hepatitis B surface antigen is positive, it can be a chronic hepatitis B infection. So in that case, you are fine that you do not need to give vaccine. You actually have to make the HBV DNA, get the HBV DNA viral load, and actually with the ART, it will be treated. But if HBs antigen is negative, the patient can be previously infected and has cleared and is anti-HBs antibody positive, which will not need vaccination. The patient can be previously vaccinated with antibody positive, which will not again need vaccination. But HBs antigen negative also means that the patient may not be vaccinated, may not be infected, which will need vaccination. So currently, our guidelines is meant for public health. But what I discussed is mostly the ideal situation. So probably when we will be treating patients individually, probably we would like to do the anti-HBs antibody titer along with HBs antigen and anti-HBC protein. So that is my comment. And I completely agree with Dr. Rewari. According to the guideline, it is only the surface antigen.
Okay, Chaitanya, any last one-liner comment from you?
Sir, mRNA vaccines actually can be used by encoding the tumor-associated antigens. This is something very new that is coming up in cancer immunotherapy. This is more into personalized therapies. So specific cancers accordingly, along with the molecular levels, we can plan giving them.
Brilliant. So I don't see any other questions. So thank you to the organizer and thank you to three top excellent speaker. We have learned a lot, and I hope when this adult immunization society particularly go forward in India and rest developing parts of the world, I hope that many of these recommendations from this session particularly would be included. Over to the organizers. And thank you again for the listeners as well as the speakers.
Thank you, sir.
Who will take over? Review? Or, yeah, okay, Sonal.
Dr. Ibu Vasu, are you there? Dr. Ibu Vasu, are you there?
Hello, am I audible?
Yeah, audible. Please
Okay.
continue, Ibu.
So, thank you to all the panelists, thank you to all the speakers of the symposium, and especially thanks to Professor Swarup Sarkar for chairing the session. So, our guests are most enriched by this discussion.
Dr. Ribu, sorry to interrupt you here. I'm Sonal here. So I would again insist that all the speakers, moderators, chairperson can stay here.
Right.
In the same hall, we are initiating the panel discussion, which is scheduled from 8:30 to 9 p.m.
Right.
Wherein Dr. Ribu Basu is moderating the session.
Right.
And the topic is update on malaria, chickenpox, DPT, etc. vaccines in New Horizon.
Right.
We will be having few more panelists joining here on the same link. So just give us 5 more minutes. We would initiate immediately the panel discussion, which is scheduled.
Okay, and
I would request all the panelists to be here on the chair to take the session ahead.
Okay, and Dr. Sonal, please announce in the hall A that we are scheduling it in hall B, because maybe some.
Yes. That is what we have.
Right.
There is one more session still going on in hall A, which will take a bit along. Right. And hence we have shifted the discussion here in hall B.
Right.
So thanks for cooperating, and just give us 2 more minutes. We'll request all other panelists to join here in hall B. That is Edward Jennar.
Okay, so and please at least in the chat say that it is in hall B. Okay, in Edward Jennar. Okay.
Yeah. It's done.
Thank you, madam. Okay.
Yeah. Thank you, doctors, again. And let's move ahead for the panel discussion in next few moments.
Dr. Ibu Basu. Hello. Hello, Dr. Ibu.
Patu sir.
Yeah, Dr. Ibu, if among ourselves the distinguished chairpersons as well as our speakers of the 2 sessions are still there, so we can have talk among ourselves if there is any questions, any queries, or any statement from our distinguished.
Exactly, sir. Exactly. So,
okay.
Right.
Hello.
There have been some questions. So, I think Shandon has replied to 1 or 2 questions, and if the audience have any question, they can type it in the chat box and ask that questions. Okay, so that we can put it to our esteemed speakers.
My one statement to Aditya Das. That time we couldn't we couldn't continue our discussions because of the shortage of time. Dr. Aditya Das, are you there? Hello? Hello?
Dr. Aditya?
Are you online, Dr. Aditya Das?
She has raised her hands.
Probably he's not there. Okay. Probably Dr. Diwari has having some session somewhere else. That's why he has left.
Okay, sir.
Likely.
Okay, so we are waiting for the panelists, and I've already sent them the link, so maybe they will be joining soon. Okay.
Yeah. Dr. Dibu, do you have any idea?
Yes,
about Hall A? How many times they will?
Hall A is actually like slightly running behind time, so we are already 20 minutes late here also. So we have shifted the panel discussion here only, and they are announcing it in Hall A also, and to the audiences, so that those who are interested can join.
They will join here.
Right, sir. Right.
Their discussion is over.
Right, sir.
Yeah. So it's request from our end to all the distinguished delegates as well as distinguished speakers and chairpersons to stay back for a few minutes more. So within few minutes, definitely the other panelists will join in Hall B, that is Louis Pasteur Hall, and we'll continue our panel discussions soon after them. Please stay back for a few minutes more with us. What I think, Dr. Basu, hello. What I think, Dr. Basu,
Yes,
many
yes.
of the doctors here who are trying to, popularize this adult immunizations, starting from me to eminent speakers. Many of us still not vaccinated properly.
Right, sir.
Some of them definitely partially vaccinated, but as per guideline, we are not maintaining. So we have to take care of ourselves, our family members. Then only our body language will be something different to convince the people.
Yes.
What is your opinion regarding this?
Sir, my opinion is charity begins at home itself. Okay, so
Yeah,
right. So vaccination begins at home itself, and until we are ourselves convinced that we should be vaccinating, we should vaccinate ourselves, our relatives, our parents. It is very difficult to convince the patients too. Okay, so
really we are lagging behind to a great extent. So for vaccinations of the adult persons are concerned, vaccination mean the vaccinations of the children only. So I think our another eminent person on infectious disease, Dr. Jogiraj Ray, has come. So most welcome, Dr. Jogiraj Ray, as well as Kaushik Mitra. Everyone is most welcome over there. So I had a talk with you regarding our API. Now your talk in API midterm update.
Yes, sir.
Okay, I had a talk with you. Now we will have talks only on adult immunization.
Okay, thank you, sir. So, Dr. Shonjit, can you please switch on your video and your audio?
Yes.
Okay, okay.
Can you see me?
Yes, you're visible and you're.
Am I audible?
You're
Okay.
audible and visible. Okay.
Okay.
Dr. Kaushik, can you please say a few words so that we can just check your mic and video?
Okay. Am I audible
Yes, yes, you're audible.
and visible
Right.
too? I think so.
Right, right, right. Dr. Pravid Kosh?
Yeah, I think I'm audible. Look.
You're audible. Pravid, right. Okay. So all of our four panelists for today's panel discussion are here. Dr. Harivas Chopra will not be able to join because he has got some other commitments, so he has to leave. I request Sonal Madam to please pin the four panelists to the screen so that they can be shown in the screen together, if possible. I have got the privilege of introducing our esteemed panelists today, and I am introducing them one by one. Firstly, I am introducing Dr. Pravid Kosh. I have in fact met him just 1 week ago in Dibrugarh. So he is a public health professional by training and alumni of Medical College, Calcutta, and a post-graduation from All India Institute of Hygiene and Public Health, Kolkata. He has been involved with various multidisciplinary research and capacity building activities in the field of immunization, and he has participated in multi-stage vaccine freezing studies, effective vaccine management, and AFA investigations at state and national level. After 15 years in medical education service, he is presently working as scientist in ICMR RMRC Dibrugarh. So, welcome Dr. Pravid Kosh to this forum. Thank you for giving your time. Now, I have got the privilege of introducing to you Dr. Jogiraj Ray, who is quite a known figure, maybe to many of you. He is MBBS MD DM in infectious disease, expert for AMR and antimicrobial stewardship planning and implementation by WHO and COVID management by the government of West Bengal. His area of interest is clinical care related to epidemic and highly infectious diseases like Nipah, corona, fungal infection, TB and NTM, and zoonotic disease. He has been working in the field of tropical medicine for 10 years. After that, he went to AIIMS Delhi to study DM in infectious disease. He has completed it in January 2020, and he has worked tirelessly in the COVID battle in the IT hospital. So hats off to him for that. After that, he has also consulted in hospitals like MR Bengu, CNC Rajarhat. He has been working with CSIR ICMR to run various randomized control unit. So welcome Dr. Jogiraj to this forum. Thank you for joining us. Next, I have got the privilege of introducing Dr. Kaushik Mitra. He is MBBS DO MD in Community Medicine, currently acting as Associate Professor, Department of Community Medicine, Burdwan Medical College. He is involved actively in various national organizations like IPHA, where he is the Central Council member. He is the Treasurer of IPS and West Bengal chapter. He is an examiner of community medicine in WBHS and other universities. He is a reviewer of many journals like IJPH and Journal of Comprehensive Health. He has got 30 publications in national and international journals and contributed in the ISM textbook of community medicine. So welcome Dr. Kaushik Mitra to the forum. Next, I would like to introduce to you Dr. Sanjeev Bandyopadhyay, who said that he doesn't need any introduction. So that is why I'm keeping his introduction very short. He's currently working as the Associate Professor of Community Medicine in Burdwan Medical College. He's involved in various activities, various professional organizations like IPHA, IMA, where he's an active leader, and he has contributed relentlessly to the capacity building in public health. So welcome Dr. Sanjeev Bandyopadhyay to this forum. Okay, so with this background, I am starting today's discussion. Today we shall be like in this 2 days of extravagant academic cheer. There are many topics that have been discussed, but still there are several vaccines which we will find that we cannot include them in this very small like area. So that is why we have devised this panel discussion to give you an idea of the newly emerging vaccines. So my first question to Dr. Jogiraj, please. Okay, so we have been thinking of vaccines for several diseases, and to be very frank, PPDs have decreased drastically over in India. We have often given typhoid vaccines to our children, like typhoid and all those things, but they are still not in the national program, and still several kinds of research are being done. So, will it be possible for you to elaborate about typhoid and cholera vaccines? What do you think is the current status, and what is the way forward?
Probably the typhoid vaccine will come in the near future. But the problems with the typhoid vaccine available is the most effective vaccine till we have is basically a costlier one is conjugate vaccine. That also don't cover the all types of positive organism, like paratyphoid A is not covered by that. So that may be the cause that is not so much popular, and its availability is really a difficult thing because we have prescribed some of the patients and they are not able to get that in the gray market also. So the availability of vaccine is not much good in if you consider the newest one, the conjugate vaccine, which is possibly the most effective one, where the prevention of severe infection of typhoid is around 50 to 60% like that, and then that is also effective for more than around 5 years. So it could be a good weapon if we use this vaccine in the areas where there are pockets of resistant typhoid also. So after the paper from the Pakistan, the Hyderabad area of the Pakistan, where you get the severely highly resistant typhoid, where the only option was meropenem. So this is probably everywhere in subcontinent, not in Pakistan, and there are patients where they are not responding with for even 14 days of ceftriaxone also. So hopefully the typhoid vaccine will have a good role if we make it available and affordable for the community. Then it could be possible. And regarding other vaccines of typhoid, like typhoral, the oral vaccines and other typhoid vaccines, thus effectiveness is around 50% like that, and that is also for 2 to 3 years protection. So but there also the availability is not that good, and it doesn't covers all types of positive organisms. So it will take time. If we can make it available and affordable, it's possible. And regarding cholera, I would like to say that cholera vaccines cholera epidemics are going on everywhere. It's not that they are not happening in classic cholera belts of areas in and around Gangetic West Bengal to the Tamil Nadu, the classic Bay of Bengal kind of area, where low-lying areas, high water logging, and after rain, the cholera is happening everywhere, and every hospitals including the primary health centers knows that where the diarrhea doesn't respond, give 3 doses of 3 tablets of doxycycline. So that's why we are keeping cholera with ORS and doxycycline a check. So we are going for the treatment, not for the prevention with vaccination. That is the notion. When you get a cheap treatment and that is very affordable, why we are going for a possible costly vaccination? But that vaccine that we are having for cholera, see, there are multiple vaccines, and some of the vaccines are not effective against our 0139 strain also. So having a vaccine which is effective for typical Indian strains like O139 and other also. So we have less options, and their effectiveness is around 40 to 50%. That is the probable cause of thinking that it may not be mass effective for the society, where you have a cheaper treatment, and oral rehydration solution is also a good answer for cholera. So that is keeping the cholera vaccine in check.
So thank you, because you have brought out many important topics like the balance between primary and secondary prevention and the cost part of it. So maybe vaccination is not a single directional decision. It has many directions to follow. So thank you for bringing this topic out. That takes me to from intestinal disease to some vector-borne diseases. So vector-borne diseases are something which we are still unable to conquer, and the first thing or the second thing that comes to our mind is why not vaccinate? So Dr. Mitro, can you enlighten us on the progress of vaccines in dengue and malaria?
Yes. Recently, as you all know, that malaria vaccine is licensed by WHO on 6th October 2021. And this is RTS-S vaccine. And first of all, the story behind it is that they have trialed it in 3 countries like Ghana, Malawi, and Kenya. And all these are in sub-Saharan Africa. And this vaccine is against Plasmodium falciparum only. And they act on sporozoites basically. So now this vaccine will be available mainly for the children in the sub-Saharan Africa. Not the trial has been going on in the adults too, but right now it will be available only for the children in sub-Saharan African countries, and mostly these 3 countries, and they have incorporated the malaria vaccine in their routine immunization too. And here I would like to mention something like the vaccine has a very good safety profile for the children, and it is easy to deliver. And what has been advocated is that although the vaccine will be given, but insecticide treated bed nets should be used along with the vaccines so as to bring down the Plasmodium falciparum in that part of the world where it is very much prevalent. And it will be incorporated in the national immunization program in these countries, and it will start from generally 5 months of age and go in 1 month interval, and again a booster dose at around 18 months. So right now we are thinking of giving malaria vaccine to the children only. Later on, I think the adults will also be included in this malaria vaccine, and it will also spread to the other part of the world. This is more or less the update on the malaria vaccine. And regarding dengue, at first the dengue vaccine, it was first licensed in Mexico in 2015, but there were so many trials going on and on, so they could not incorporate in any of these schedules in any of the countries. But from 2022, the dengue vaccines are likely to be introduced in and has been approved by US FDA too. So they're going to introduce in America and some other parts of the developed countries as well. But here also, it is recommended for 9 years to 45 years of age. But in US, they are giving it from 9 years to 16 years around. And this will, they are thinking that this will bring down the severity of the disease. And what is most important here is that dengue vaccine will be given to only persons who are affected by dengue previously, not the persons who are not affected at all. So before giving dengue vaccine, it is mandatory to check the IgG level, or they should have positive report of previous history of dengue infection. Otherwise, if they had a second infection with dengue after taking the vaccine, it will mimic like the second infection of dengue and may lead to a severe disease. So the primary prerequisite of taking dengue vaccine is they should and must had a previous infection and documented infection with dengue. So even again, if they were affected with dengue, this will go like the third episode or fourth episode, that is less severe. So this is more or less about dengue vaccine, which is going to be introduced in 2022 in some of the countries around the world, around 20 odd countries.
Okay, so again, we have the same point of whether to choose a primary prevention like ITN or vaccine as a primary prevention. So all these various modes of intervention will go side to side, and we have to keep various things in our mind to choose whether the vaccines are effective or not. Regarding efficacy, we may be having a lot of trial, but regarding the effectiveness, we really need more data. So speaking of the vector-borne diseases, there is one vector-borne disease which has got a proven effectiveness of vaccine, that is Japanese encephalitis. And I think Dr. Pravid Kosh is working on a Indian strain of Japanese encephalitis vaccine currently doing trial in the northeast regions. So can you please enlighten us on this new vaccine which you plan to introduce soon? You are muted, Dr. Pravid Kosh, you are muted.
Okay, sorry. Thank you, Ribu. Good evening to all. Regarding Japanese encephalitis vaccine, this is not a new vaccine which is going to be we are going to run a trial for this. Already we are having in India multiple different types of Japanese encephalitis vaccine. In India, we started with SA-1414-2, that is a live Japanese encephalitis vaccine, which has got good success story among the children and also some among the adults. For last 3 to 4 years, we have also introduced 2 inactivated vaccines in Indian in the national immunization schedule, and also for adult vaccination in certain parts of the country. Japanese encephalitis is one disease where, as you rightly mentioned, which has got a vaccine with proven efficacy and certain amount of effectiveness also. What Kaushik suggested about dengue and malaria, that we are not sure when to introduce, but the Japanese encephalitis vaccine has been there since 1930s. And in next almost 4 to 5 decades, in countries like some countries like Japan, they have eliminated Japanese encephalitis disease with vaccination. Later on, when we got the Chinese vaccine, that is SA-1414-2, it was mainly meant for the children. Later on, since 2014, in certain identified districts where we thought or the data showed that there has been a significant shift or epidemiological shift in the age group of Japanese encephalitis, their adult immunization was started. And over last 3-4 years, or rather since 2014 onwards, there has been a significant decline in Japanese encephalitis mortality and cases among adult population also, but specially restricted in certain states. It is not given all over India. It is meant for at-risk population, and so it is mostly restricted in those districts where adult populations are getting infected, as per the reports available with us. So, and about the trial, what we are talking about, this is not started as yet. That will be only, we are proposing something that it is not meant for adult population.
Right. So, yes.
So regarding, some studies have already been done on adult after the adult JE vaccination in Assam, from where I am working. They studied, they did a case control study among the Japanese encephalitis cases and age and sex match controls, and tried to understand what is the role of adult Japanese encephalitis vaccination over the disease occurrence. And they found a significant association with vaccination coverage and the decline in or the reduction in case load among adult population. So That has been done. That has been published in last year. I think last year, August 2021, this report was published.
Okay, so we do have some observational study reports showing that this may be effective in improving outcomes in adults also. So that is certainly encouraging for us because like this is quite a deadly disease and this is endemic in areas like Assam still. So with this background, I'm moving now to Dr. Sanjeev Bandyopadhyay because like you have been practicing geriatric medicine and seeing geriatric patients for long, and often we see that the varicella vaccine or the zoster vaccines, the chickenpox vaccines are often not given in them, mostly not given in them, which is a common thing in the Western countries. So with this background, what do you think about these vaccines? Do they have got a potential of really working in Indian scenario with regards to both efficacy and the cost effectiveness?
See, Ribu, if we consider our childhood vaccination, even in India, it was not in routine immunization program. The basic dictum is if the burden of the disease becomes a major public health problem, then you have to vaccinate those persons. That's why some countries now consider vaccinating the children against chickenpox vaccine or varicella vaccine. Now, if you see the age transition, that is, there is a shift of age from lower age to more than 15 years of age.
You have accidentally muted yourself, Dr. Bandyopadhyay.
Sorry, one phone has came. That's why the line has been disturbed. So, am I audible?
Yes,
Hello?
you're audible. Yes, you're audible.
Yeah. So as there is a change of age or transition of age, if we see in contracting the disease, now the WHO what says that if it becomes a major public health problem among the adolescents and adults, then we have to consider varicella zoster vaccine, which is known as OCA VZV vaccine. But we should remember that this vaccine should be given as a 2-dosage schedule, because in children we can give even 1-dose schedule. If we give 2 doses in children, it will increase our effectiveness. But in case of adults, we must have to give 2-dosage schedule. The next thing is there are some contraindications. Like if someone is pregnant, we must not have give this vaccine to those ladies. And if someone has given this vaccine, then he should defer a pregnancy for at least 4 weeks from the date of vaccination. If we think about the immunocompromised patients, yes, there is contraindications, but if we consider the other risk that if they are infected with these vaccines, so according to WHO, they may be given this vaccine if we weigh the cost and benefit or something like that. Another thing is regarding traveler, what WHO says that it is not routinely recommended for the travelers to give varicella zoster vaccine. In HIV infected patient, if the CD4 count is more than 15%, even if the patient is going on highly active antiretroviral therapy, this vaccine should be given. But if the CD4 count is less than 15%, there is no solid data, so it is not recommended in HIV infected patients whose CD4 count is less than 15%. Apart from that, if there is some susceptible household contacts of a solid or immunocompromised patient, like solid tumors, ALL, something like that, they should be vaccinated. Even if the healthcare workers should be vaccinated, even if this vaccination is not in the routine immunization schedule. And regarding herpes zoster vaccination, it should be given only to the immunocompetent persons. It should not be given to the immunocompromised persons, and there is no solid data. So there is no such recommendation from WHO's point regarding herpes zoster vaccination. Thank you, Rivu.
Thank you. So that was like a good thing you said uh, regarding these vaccinations, because we often find that people are asking us that whether we should take that. They have heard it from some Western counterparts regarding they have already taken. My friend is in USA. They have taken this vaccine. Should we take? So we should have a certain guideline to guide them for in evidence-based manner in India too. So.
Yes.
Like if you go into the WHO's list of vaccines, you will see many vaccines in pipeline like herpes simplex, enterotoxicogenic E. coli, group B streptococcus, RSV, etc. It is very difficult to go into all of this in this very short span of time. But certainly a very exciting development is the geohelminths vaccination. So Dr. Jogiraj, can you please throw some light on these vaccines against the geohelminths?
So geohelminth related vaccines mainly targeting ankylostoma and Necator, mainly, and there are others also against Trichodes ascaris. But mainly the trial that has been put forward for say 2 decades is on the anemia producing organisms like Necator and ankylostoma. So there have been a lot of studies done in the and trials done in PAHO areas like in the Brazil and Colombia, these areas, and they have found quite effective, and it can reduce around 70% of worm load in the community. So that is a very good effective tool. If we but in a public health, when you approach geohelminth, you have to think about our usual preventive mode, that is the WHO recommended wash D. So if you compare, there has been no comparative analysis between how the our wash D, like Swachh Bharat program, along with deworming, this plus it is compared with the effectiveness of soil transmitted health vaccination as a tool to reduce in the community. So this area has to be looked on, and this is an excellent area for public health research when you can compare these two arms, like tool for prevention in the society, soil transmitted helminth in the society, and still now the vaccine against soil transmitted helminth, most of the phase 1 in the vaccine against Necator and ankylostoma is in some areas in Brazil in stage 3. This vaccine will come within a few years, and that will be a challenging work to be done when we compare these two things and see the burden of the disease in soil regarding soil transmitted helminth. It is the commonest helminthic disease, commonest thing we encounter in public health as far as a
Right. So the network is a little jumpy, but yes, we got your point, and it will be a wonderful to have a vaccine for helminths, because we know that the anemia part is also a big. The helminths are a big cause of the anemia part also, and we are still lagging behind in the reducing of anemia burden. It's still around 22-23%. So this is very like disheartening for us. But let's see what happens with this helminth vaccine too. So with this, an open question to the panelists, that we have been talking about the newer vaccines. There have been some trials going on, mostly in the children, mostly in high risk groups. So, like, how do you see these vaccines getting incorporated into adult immunization schedule in India in the coming 10 years? Any open comments from any one of you?
See, regarding typhoid, I think this may come sooner or later, and typhoid is a still big problem, and although the mortality of typhoid is low right now with effective drugs, but the morbidity is quite high, and we lost lot of working days on these things. So it may come in different adult immunization schedule. That may not be possible for government to recommend as a tool for public health, but it can be, it will come definitely from different immunization program that has been advocated by societies like us.
Right. So again, that tussle comes of private versus government. Many of the vaccines are available in private, and government either makes a blind eye to that or doesn't know that. I do not know. So Dr. Pravid Kosh has been working in vaccines for 20 to 25 years. So from your position, is it possible to say anything about when India is going to introduce a program for adult immunization, and when can these vaccines be in the schedule? Any take on that?
It is very difficult to comment on that because usually, as we all know, that vaccination is costly. It is not about vaccine only. It relates to the cold chain. It relates to the manpower and all. And we have to establish from the public health perspective that basically vaccination at present can save us millions. So what now government is promoting is disease specific and risk based vaccinations like hepatitis B is gradually being promoted in certain occupational risk groups. Maybe probably after the COVID and more or less it has been established that a successful vaccination program can be introduced as a PPP mode, because with support from government and with support from private sectors, it is possible. So this can be an eye opener, and possibly this is the way out with which we can promote different vaccines, because what Dr. Jogiraj was suggesting or was that typhoid vaccine might be important. And I just want to add that it might be important also to avoid antimicrobial resistance. If we can have a successful vaccination program, not only for children, also for adults, it can it can help us in to certain extent, at least to reduce the antimicrobial resistant burden because of irrational use of antibiotics. So these are the things which we can look into, because who are the policy makers, they need to be convinced about the cost effectiveness. That is the primary concern. In COVID, somehow people were convinced. Now, in the last, in another session, I heard that possibly in HPV, we are going to introduce single dose regimen. So this is one way of if we can have this type of regimens where some cost cutting is possible. Possibly these are the way outs. We need to look into the operational challenges, and all of us can contribute. So it is not a guideline as such. Mostly it is risk-based approach now. Suppose veterinarians, they can have some certain vaccines. Suppose we as an occupational risk group can have certain vaccines, but in general population, it is very difficult. Geriatric population also have certain vaccines. Suppose who are going through dialysis, who are having other malignancies and others, they are definitely prescribed certain vaccines. So these will be there. And with the increasing problem of respiratory problems, asthma and all, so certain other vaccines are also being promoted. So it is not a blanket call for all vaccine to be included in one shot. Maybe it will be introduced phased manner in certain pockets. Gradually it will be incorporated. maybe the total vaccination program may need to be revamped. Along with the universal health coverage aspect to keep in mind. That's all my take.
Okay, so there is
Maybe
two very,
others can comment.
yes, two very important points you made about the PPP mode and the entire vaccination program being revamped. So, Dr. Kaushik, we have seen that India is a like powerhouse of vaccines. Okay, because in COVID they have been able to vaccinate a huge number of population in a very short amount of time. I'm not going into the controversy of whether it was required or not, but India has got the logistics. It has shown to the world. So, do you think that this kind of operational capacity can be leveraged to deliver these adult immunization vaccines, and this is an opportunity for us to use this logistics? Dr. Kaushik, you are muted.
Rightly said, Dr. Ribhu, that regarding COVID, it was mainly adult immunization, and India was one of the best to deliver the vaccination to millions. But regarding other adult vaccination, we do not have an adult scheduled right now. But we can definitely use the setups and the logistics which have been used by the COVID vaccination. But first of all, we should have a guideline which vaccine to introduce and which would be cost effective, as said by Dr. Pravid Kosh, that we should introduce in a phased manner which vaccine will be introduced first, and we can definitely use our setup which we have set for the COVID vaccination. But there should be on priority based approach, and there should be a movement from all that regarding adult vaccination, just like the childhood vaccination.
Okay.
All are thinking of childhood vaccination, but there should be some thought on the adult vaccination too.
So taking cue from you that always I know a person who is working in like vaccine politics and politics in public health, and that's Dr. Sanjeev Bandyopadhyay. So the voices are not there. Okay, and so as a member of various professional association, how do you see the voices being raised, and what kind of policy decisions may be altered from the professional bodies regarding these movements? Last take, please.
See, the main issue is the public health burden. Policymakers, what usually see, if you see the example of COVID vaccination, it is one of amongst those few vaccinations which was started among the elderly people first. And this has transmitted down to now to the adolescents, 12 to 14 years of age group. So it has been started to the elderly group, more than 65 years of age, or healthcare professionals, something like that. Because if you see that if we see that there is a transition of age in the epidemiology of the disease, then we must have to think about vaccination. If you see, even in case of diabetes, in case of COPD, we know that we used to tell the patients to take pneumococcal vaccines, influenza vaccines. Why those? Because there are susceptibility. There are chances of being infected by those infective agents. So for me, or as a policymaker, what I suggest that issue is what group of people is affected most. This is the basic dictum of public health. So if adults are affected most, they should be vaccinated first. If childs are affected most, they should be vaccinated first. Now, there is no politics, nothing else. Thank you.
Okay. So thank you for your last words, Dr. Sanjeev. And so thank you to all the four speakers, Dr. Jogiraj, Dr. Pramit, Dr. Kaushik, and Dr. Sanjeev, for your excellent deliberation. We had a very interesting session. So please do watch the session on the YouTube also and give your comments. Thanking again to ISAI for arranging this very visionary program on adult immunization in India, bringing in speakers from all over India and the world. With this, I'm handing over the mic to Dr. Pravid Kosh and Dr. Saurabh Kole for the concluding remarks, please.
So thank you very much. and it's fine to see all of my good friends, Yogiraj and many others. And in our conference, Dr. Saurabh Sarkar also had joined. So basically, we can think this program in such a way that a seed has been implanted. And in fact, doctors from different specialties have joined here. And in our question box, we have seen that most of the doctors are asking for that what should be the guideline, whether any existing guideline of immunization, etc., etc. So it's a brainstorming work, and I am sure that one day all the societies will come together and form a guideline. And I just want to remind you that from tomorrow, this is the World Immunization Week, and we have started this program here. But what I feel that a lot of work to be done, and every specialties, it's starting from public health specialties, clinicians, and even in who are working in the critical care. Whenever I see some patients in critical care, I found that many preventive care could be done so that these patients' critical illness can be minimized. So I think that every societies should come forward, IPHA and API and all the other organizations should come forward. Even you see that in one session, that is the HPV vaccination, lot of discussion was going on. So gynecological society is also playing a pivotal role in this prevention of the cancer, uterus, etc. So I think that we should, those who have joined us, in future also we should work together, and we can do something for the immunization, adult immunization in our country. With these few words, I am concluding the session, and I just want to remind one thing, that you see that whenever we have started organizing this program, we thought that how many doctors will participate. So I told our technical team that keep it around 500. So ultimately, just now I found that almost 1,500 doctors have participated in both hall A and B. So there is a lot of curiosity, lot of enthusiasm amongst the doctors regarding the adult immunization today. Probably that COVID also has increased this importance. So I'm sure that in future, the delegates, the faculties who are here, in future will work together. And I just want to remind you that tomorrow our session will start at 5, and everybody should join here at 5 and to make this conference a great success. Thank you all.
Thank you, everybody, and good night. Have a good sleep and join tomorrow at 5 p.m. sharp. Thank you.
Thank you. Good night.
Thank you. Thank you.
Thank you.
Good night, everybody.
Jignesh,